Today, I want to look at the case of a 85-year-old gentleman who's stuck in ICU for a few months, and the family is asking if, their family member can go home with intensive care at home. My name is Patrick Hutzel from intensivecareathome.com, and I will look at a case today that we've been asked to transition home. So this is a case of a 85-year-old man who's been stuck in ICU for about 3 months now. He's ventilated, he's got a tracheostomy, he's got a medical history of hypertension, he's had a stroke after coronary artery bypass grafts, he's got COPD, he's got history of significant hypertension, history of a traumatic brain injury, also community hydrocephalus dysphagia, he's got a PEG tube, he's got chronic kidney disease, and he has an altered mental status, and he has shortness of breath, which is one of the reasons why he ended up on a ventilator. So a few months ago, this gentleman went into the ED with aspiration. He ended up on BiPAP with a mask, non-invasive ventilation, but couldn't tolerate it for too long. And then he ended up intubated and in ICU. A couple of weeks later, after he wasn't waking up, after he couldn't be weaned off the ventilator, he ended up with a tracheostomy. And since then, he has been difficult to wean off the ventilator. He has been failing spontaneous breathing trials, and the family and the ICU team don't see a way forward at the moment to wean him off the ventilator, and he's stuck in ICU. This gentleman is also diabetic and insulin dependent, and he's also got a history of sepsis, hypernatremia, which is high sodium, and hyperkalemia, which is high potassium, which is due to his acute kidney disease. With the acute kidney disease, he's not on dialysis, and it is managed with diuretics. So, that makes it easier for him to actually go home. This gentleman is also having a history of seizures, and he's currently on Keppra for anti-seizure or for seizure management. The gentleman's code status is full CPR as per his advanced care plan. The gentleman is off all inotropes or vasopressors. He's hemodynamically stable. His current ventilator settings are: he's in an AC mode with a ventilation rate of 18 breaths per minute delivered by the machine and guaranteed. His tidal volumes are 350 mils per breath. His PEEP is 5 centimeters above water, and he's on 24% of oxygen, which is really minimal. Room air, the air that we are breathing in, is 21%, so 24% is minimal, but he cannot be weaned off the ventilator. He has been failing spontaneous breathing trials, and therefore, the best bet for now, given that he can't be weaned off the ventilator, is to go home. The family had enough to, quote unquote, live in ICU and have their family members stay in there. Not that there's anything wrong with the care that he's getting in ICU, but obviously they have concerns that their family member is not getting the quality of life he could have at home, and that the family doesn't have the quality of life if their dad was at home. So once again, it's a win-win situation. And what is happening from an ICU perspective as well is ICUs need beds. ICU beds are in very short supply, they're in high demand, and therefore they're very expensive as well, $5,000 to $6,000 per bed day, right? So from a funding perspective, it also makes sense to use intensive care at home, because that cuts the cost of an intensive care bed by around 50%. And it frees up the most sought after bed in a hospital, which is the ICU bed. Once again, it is all about creating that win-win situation. So what needs to happen next? What needs to happen next is obviously for the funding body to agree to pay half of the cost of an ICU bed, which is a no-brainer really, given that we can deliver the same level of care at home, especially when patients are in a stalemate and they have no further treatment at this particular point in time. It might develop into a palliative care situation. We don't know yet, but that's where it might go. It might not. Family has said that their dad wants to live at all costs. Now, what needs to happen next? Funding needs to get organized. Equipment needs to get organized, such as a home ventilator, 2 of them for backup, suction machines, monitors, nebulizer or nebulizer machines, a humidifier for the ventilator, a dry circuit and a wet circuit, hospital bed, wheelchair, hoist, or a lifting machine. All of that needs to be organized, but that is bread and butter for us. We've done it many, many times. And then lastly, and most importantly, a team of critical care nurses needs to be hired in cooperation with the client, of course, to make sure that not only we have the right skills, but also we have the right personality fit for our clients so that all shifts can be filled. I know it sounds overly simplistic, but that's the process. And it can be implemented because we've implemented it many, many times with our clients. We've delivered hundreds of thousands, if not millions of hours of intensive care at home nursing by now. So if you have your loved ones stuck in ICU in a similar situation, ventilation, tracheostomy, PEG tube, reach out to us to help you and your family to get your loved one home. Or if you're in ICU watching this and you need help with getting your long-term patients home in a safe environment that helps you to free up your beds, your resources, your staff, please reach out to us as well. So with intensive care at home, we're currently sending our critical care nurses into the home 24 hours a day. Therefore, we are providing a genuine alternative to a long-term stay in intensive care for ventilation, tracheostomy, home BiPAP, home CPAP, ventilation without tracheostomy, but also for adults and children with tracheostomy and without ventilation, home TPN, home IV potassium infusions, home IV magnesium infusions, IV fluids, and IV antibiotics. We're also providing ventilation weaning at home. We're also providing central line management, peak line management, Hickman's line management, as well as port management at home. We're also providing nasogastric tube and PEG tube management at home, as well as palliative care services at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, the In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going into the emergency department. Therefore, we're also in the position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs around $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per day. We're freeing up the most sought after bed in a hospital, which is the ICU bed. But most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. With intensive care at home, we're currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS approved all around Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as the Department of Veteran Affairs all around Australia. Our clients and we as a provider have also received funding through public hospitals, private health funds, as well as departments of health. We are currently the only service provider in Australia that has achieved third-party accreditation for intensive care at home nursing in 2025, and we have been achieving this level of accreditation since 2012. No other provider has achieved this level of accreditation in the community and has created more intellectual property when it comes to intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. And if you're at home already and you're watching this and you realize you don't have the right level of support, or if you're stuck in an ICU long term, or if your family member is stuck in an ICU long term, I'll give you a real world example today. One of our first clients about 10 years ago when we first got started was a client who was at home initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, it's dangerous and negligent having support workers looking after a client at home on a ventilator with a tracheostomy. That is like flying the airplane with a cabin crew instead of the pilot. Because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies or even dying if they don't have a team of critical care nurses looking after them 24/7. This is actually evidence-based that in the community, it's documented in our mechanical home ventilation guidelines that you can find on our website at intensivecarehome.com, where it's clearly documented that only and exclusively critical care nurses with a minimum of 2 years critical care nursing experience can look after ventilation tracheostomy at home safely. Think about it, in an intensive care unit in an ICU in a hospital, you wouldn't have support workers looking after a critical care patient on a ventilator with a tracheostomy. So why would anyone in their right mind do that in a home care environment in the community? People have died because of this support worker model. So eventually this client found out about us, the ICU that he was going back to found out about us, and we were proving our concept with this client very fast. When we worked with the client, we sent him intensive care nurses 24 hours a day, and he never ever went back into ICU ever again. And we were proving our concept there very fast. We can do the same for you if you're not safe at home, which includes the advocacy for funding that goes along with it. We have always successfully advocated for our clients, otherwise we would not be in business. The same is applicable for those stuck in an ICU, similar to our case study, to what you're looking for. Reach out to us, we'll make it happen for you as well. We can take you through the right steps. And that is also why we're providing level 2 and level 3 NDI support coordination. We have a team of NDI support coordinators and they have a wealth of knowledge. I've done an interview with Amanda Riches, one of our NDI support coordinators. I'll put a link to an interview with Amanda in the written version of this blog below the video. We're also providing TIC case management and WorkSafe case management in Victoria with Lucy McCodder. And if you're an NDI support coordinator or a case manager from another organization watching this, and you're looking for nursing care for your participants, please reach out to us as well. If you're looking for funding for nursing care for your participants and you don't know how to go about it and what evidence to provide, I encourage you to reach out to us as well. We will help you with the right level of funding and with the right level of advocacy. We're also providing NDI specialist nursing assessments done by critical care nurses with a legal nurse consulting background. If you're a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic and high-performing team of critical care nurses in the community, we're employing hundreds of years of critical care nursing experience combined. If you're looking for a career change, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, and in Warragul in Victoria. If you have worked in critical care nursing for a minimum of 2 years pediatric ICU ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I have a disclaimer, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients do want the same staff coming over and over again, because they're very vulnerable and very special. That's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We're looking for consistency and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts. And if you're really keen on building relationships with us and with our clients. And if you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can help you eliminate your bed blocks in ICU and ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds, and in most cases, you won't even pay for it. Even if you do pay for it, it is much more cost-effective than what you're paying in ICU and ED for, and you get the same level of care and you're freeing up your beds. And if you're a hospital executive watching this and you have bed blocks in your ICU, ED and respiratory wards, home TPN, of course, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US or in the UK and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.